lecturer's interest lies on the complex polytrauma patients and the use of endovascular techniques in their management. He is also a recipient of numerous awards, such as Dean's Award for Teaching Excellence, as well as Outstanding Tutor Award and the NUHS Leading Excellence Award. He is also an educator involved in undergraduate education and surgical curriculum development. He completed fellowship in advanced trauma and vascular surgery in the Royal London Hospital and masters in trauma science at Queen Mary University of London. He is a fellow of the Royal College of Surgeons, Edinburgh, and a consultant trauma surgeon and clinical lead for trauma, Department of Surgery, National University Hospital, also a consultant vascular surgeon at the Department of Cardiothoracic and Vascular Surgery at the National University Health System. To deliver to us the lecture on endovascular adjuncts in damage control surgery, please welcome Dr. Raj Menon.
Okay, good evening, everyone, and thanks a lot for joining us this evening, and thanks to the committee for inviting me to speak for this talk for a topic which is quite close to my heart. Today we'll be talking a little bit about endovascular adjuncts and how they relate to damage control surgery. So not particularly deep into vascular trauma itself, but in the context of damage control surgery, in a complex polytrauma patient, how can we use our various endovascular adjuncts to help us? So we'll go through a couple of cases of endovascular adjuncts and the potential uses. We'll go through some of the training which I think is required for trauma surgeons to embark on the use of these endovascular procedures, and also if for many of you who are running your own systems in your own hospitals and are part of a trauma team, how do you build protocols for endovascular supported damage control surgery? So I'll just run through a couple of case examples just to go through a little bit about how we apply these techniques sometimes for a complex polytrauma patient. So if I give this is a case that we had some time back, a 40-year-old male in a road traffic collision. His blood pressure was falling rapidly in the emergency department. He had a large left hemothorax, he had a widened mediastinum. His FAST scan was positive. Pelvic X-ray showed open book pelvic fracture. And now you're in a classic dilemma which a trauma surgeon will face. Where is he bleeding from? Is it from the pelvis? Is there major abdominal bleeding? Is there an aortic transection because it's a widened mediastinum and a left hemothorax? And as such, the way we approach these cases now with an endovascular support is to bring these patients to the hybrid suite, which Prof. Amit Gupta had just talked about earlier. And this is a room which allows us to use a couple of different techniques at the same time in order to diagnose as well as to treat the patient. So when the patient is being induced, quickly got some access into the right femoral arteries. This can be either through a cut down or via percutaneous access and inserted a sheath. And how we started the surgery was first by passing a wire up to the arch of the aorta, doing an aortogram to quickly exclude a transaction, and that literally just takes about a minute to quickly exclude, and you're quite certain that at least you don't have to focus so much in that area. And before proceeding to a laparotomy, since he had a FAST positive, found lots of liver lacerations, a large zone 3 hematoma in the pelvis, and then because we already had vascular access and we have a catheter there, after packing the liver, it was just a matter of bringing down our catheter down to the celiac axis to look for bleeding, and similarly to interrogate the iliac vessels, which we could immediately see were bleeding, and we had to embolize straight away. So this is quickly running a catheter up to make sure there's no aortic injury. Similarly, checking out for other areas of bleeding from various other parts of the celiac axis and other areas of concern, especially in this context of a patient who has had no scans before. We're not sure whether there's any other bleeding going on. And here it gives us a very quick way of doing both open surgery as well as using this endovascular access to quickly go into embolized vessels at the same sitting while we're there. And this demonstrates not just the diagnostic, but the therapeutic roles of an endovascular intervention in this setting. Now, another case that we had was a young male who had an accident at work, and he fell onto a long pole. And this pole, as you can see from this very graphic diagram, had basically gone through his neck, and it had pierced all the way through and through till you could feel the pole on the other side of his neck. And it seemed to be crossing exactly where the carotid sheath was running through. And he was clearly in distress. The pole was sticking out. It was quite a long pole, and we couldn't get any further imaging for him apart from what we see here. And we knew that this gentleman definitely needs a clear exploration, control of the vessels to remove it. But again, not knowing exactly what the trajectory of these vessels are, this is where an endovascular approach sometimes helps us. Again, bringing to the hybrid OT, we just punctured the right brachial artery, put in a 5 French sheath, place the catheter near the right common carotid, and pass the wire in the target carotid vessel, so that in the event that there was major bleeding as we were manipulating the rod and exposing and controlling the vessels, we could simply blow up a balloon there to occlude the vessel while we achieved control of the vessels. So this is one of the angiograms showing that we have run a catheter. You can see the carotid going up. Thankfully, this rod just was touching the carotid but didn't injure it, and that gave us a lot of safety to isolate the vessels and later pull out the rod itself. And so that's just another example of how endovascular techniques help us in damage control surgery and in major hemorrhage control for complex cases. Now, of course, endovascular support in trauma extends all the way to the pre-hospital and ED setting. And this is clearly what we're talking about here is REBOA, Resuscitative Endovascular Balloon Occlusion of the Aorta, which is a growing role now in many major trauma centers and trauma regions around the world. It comes with a greater familiarity with vascular access, availability of balloons, but it's not a simple procedure. It's something which requires a lot of preparation, a lot of training, and very clear application of when you select patients for this. Now, I'm not going to go too much into REBOA itself because Prof. Mina Cheng, the next speaker, is going to go into this in some detail. But there's been loads of data now coming out about various attempts of REBOA use in various settings, both in the pre-hospital, in hospital, and even in the intraoperative setting. Now, just very briefly, the main role of REBOA is usually in patients who have a non-compressible torsal trauma, and also in patients with traumatic arrest. And that's quite a useful adjunct to basically establish an effective cross-clamp of the aorta by using this balloon. And in the olden days, where we required open techniques to insert these kind of balloon, percutaneous access had changed things. There are smaller access sheets now coming up, which reduces the risk of vascular complications, which was one of the key problems with REBOA in the earlier days, because putting a big balloon up a small vessel usually ended up causing quite a bit of damage to the entry vessels itself, including with complications of limb ischemia, leading up to amputations even. Broadly speaking, we use Zone 1 and Zone 3 REBOA. Zone 1 REBOA means parking the balloon right, just supradiaphragmatic, and this establishes some afterload for the heart so that you can get some diastolic filling and to supply the brain. Zone 3 REBOA in particular is quite useful if you are worried about pelvic bleeding and non-compressible groin bleeding as well. And parking a balloon here reduces the ischemic burden to the rest of the visceral vessels, but at the same time helps in reducing flow below. And we'll talk a little bit about this moving on. Now, REBOA use has been fluctuating. It used to be very, very popular, and there was a great enthusiasm for the use of REBOA. There were a number of papers, in fact, 2 papers from Japan, which also then suggested that perhaps the utility of REBOA is not really there. We're not seeing the outcomes we desire, but it was confounded by a lot of issues, including patient selection and not very good descriptions of exactly what kind of zone REBOA was being applied. But broadly speaking, there are a number of 8 or 9 trials going on at the moment, which are looking in particular at pre-hospital REBOA. And I think the results of that, of pre-hospital and the ED REBOA trials, are going to be very, very interesting when they come out in the next few years to see whether they really make a difference in these patients who would otherwise not have survived or who would have been in extremis. Now, how does this translate to the operating theatre? So far, what we just talked a little bit about pre-hospital and in the emergency room. But how about in the operating theatre? How does endovascular support help us, as described in the first 2 cases that we talked about? To me, you can divide it into 2 big groups, and the one big group is the diagnostic users. I find that having endovascular access allows you to image patients or perform on-table angiography on patients who were not imaged, who could not be imaged prior. For example, if a patient was in extremis before, you had to rush to theatre. Now you have attacked the first area which you have tackled, let's say the abdomen, but you still need to get some kind of data about whether there's any bleeding going on elsewhere. On-table angiography helps. Now, in our experience, we found that just shooting contrast into various big vessels and looking for a blush does not really help. Targeted assessments where you cannulate a particular branch is a far more effective way of finding out whether there's any active bleed and then leading on to further interventions from there. Certainly in extremity vascular injury, this is now a mainstay. Every kind of, I think our protocols probably differ a little bit from what Professor Gupta had mentioned. We tend to use endovascular, we tend to use an angiogram, a non-table angiogram for many of our extremity vascular patients, at least, if not at the initial point of diagnosis, but after our bypass or after our reconstruction, to just ensure that there's flow all the way down to the foot. And we find that's it's quite a simple procedure just to do with either in a hybrid theatre or just with a simple image intensifier or a C-arm. I've also found it very useful in patients who turn unstable and you quickly need to interrogate another cavity, and just passing your catheter up higher below the diaphragm and interrogating those areas gives you a good idea as to whether there's still bleeding going on in other parts of the body. Now, I think earlier there was a discussion also regarding these hybrid emergency room systems and these Raptor suites, which are a little bit different, which are not many centers have this because it's quite an investment in technology, it's quite an investment in infrastructure, where essentially you bring the operating theatre, you bring everything down to the level of the emergency room, you have a CT there, you have interventional radiology there, and you undertake all these interventions within that space to minimize movement of the patient and to save time. Certainly, in centers which do it, they feel that their time to hemostasis is a lot faster, simply because the angiogram, they are able to get a clear, easy diagnosis, an early diagnosis, and also intervene at the same time. In in our hybrid theatre, we are able to do something called a dyna CT. We don't do it often, but sometimes it's an interesting adjunct where we are using the C-arm essentially to perform a CT scan while we're there. So in that sense, even a patient who has, let's say, been rushed into theatre for hemostasis, we're worried he has got a head injury, running a small protocol like this in the hybrid room allows us to just clear the head and to make sure whether there's any other intracranial bleeding going on. And this can be done with contrast injected as well, or without contrast injected, so you can get plain film, so you can even get an angiogram when you're there in the form of a rotational CT as well. So that's another possible use that we sometimes do, that we can do in our hybrid theatres. Clearly, in terms of one of the key aspects in which endovascular treatment is very important is in aortic injuries and transactions. Thankfully, most aortic transactions we are able to get away with a simple TIVA and not requiring any other sternotomy or debranching, or simply because of the anatomy of where the aortic ruptures usually take place, which is at the aortic isthmus. Certainly having some form of CT helps, but even if you didn't, being able to do an angiogram on table, an aortogram on table allows you to receive quite a bit of information as well, and certainly leading to the placement of a TIVA stent This was a particularly interesting case where the pseudoaneurysm was quite proximal, and we had to cover his carotid vessels and required actually a sternotomy and a debranching. So in this case, a hybrid procedure in the trauma room where we clamped the arch of aorta, debranched the vessels, as you can see over here, to the carotid and the brachiocephalic, and then covered with a long stent to breach the pseudoaneurysm there. Clearly, for abdominal, thoracic, and pelvic angioembolizations, this is well known, and this is a mainstay of treatment for bleeding from these areas. In fact, our next speaker has published very extensively on this, and the triple therapy package 3-in-1 protocol, which Hong Kong has made famous, is certainly evidence of the fact that having this kind of hybrid approaches are really very useful and really helps to reduce patient movement and reduce the risk of rebleeding in patients with complex pelvic fractures. Now, the other use of having some degree of endovascular access is that if a patient really continues to deteriorate, you can use this as a route to convert this patient's treatment into not just for your typical angioembolization or your diagnostics, but also for more advanced kind of life support. Now, there are not many centers which can support these kind of supports, but of life-saving supports. But being able to perform ECMO, extracorporeal resuscitation in a patient who's dying in front of you, having access there makes it a lot easier to quickly institute. Thankfully, this is not a common thing that happens. This will be probably something that is going to be very rare, and even then outcomes will be poor. But again, having early arterial access allows you to quickly implement and quickly put in your bigger catheters so that you can establish extracorporeal support easily for patients who are in extremis. Now, moving away from just the clinical implications, and because many of you are active practitioners in trauma, I just wanted to share a little bit of our experiences in building protocols in endovascular techniques in damage control surgery. And I think a lot of people are worried about what is the infrastructure that you need to do this. Now, you don't necessarily need a hybrid theater. Of course, it makes it easier, but just having your image intensifier and a C-arm still allows you enough visualization, even though the field of view is much smaller, but it does allow you to, and in cases when our hybrid theater is busy, we just use our C-arms to achieve similar outcomes for patients who need a hybrid kind of a procedure. So just in a normal operating theater, with just a C-arm should be able. The same C-arms which orthopedic surgeons are using are sufficient for this. In terms of staffing, if you're doing a complex hybrid procedure, often good to have two trained proceduralists in, a trauma surgeon who has the ability to proceed with your open repair and your open management, and potentially another surgeon or interventional radiologist or any other doctor with endovascular training helping you to control the endovascular devices at the same time. And this is especially crucial in patients on REBOA. Certainly radiographer and specialized nursing support is also going to be quite important. You don't need many consumables for the initial part at least. You need puncture needles, you need to get a few vascular sheets, wires, guidance catheters, balloons, and some embolization material, and just keep that on standby in theater. And I think once you get familiar with these, putting in a sheet, putting in a wire, putting in a guidance catheter is not a very complex procedure at all, and it can be learned. And certainly there are many courses which were running actively prior to the unfortunate pandemic at this point, which used to teach many of these techniques, and I've just put some of them here for your reference, where you could actually learn some of these skills. And these are catered not at vascular surgeons, but at general surgeons, emergency physicians, interventional radiologists, and even intensive care physicians to learn some of these skills. And of course, if you are a trauma surgeon, having a little bit of exposure to vascular interventional radiology will rapidly accelerate your ability to deploy some of these skills during complex polytrauma. And the evidence is also quite clear. The more you do, the better it gets. And this is actually a table looking at REBOA balloon insertions and how much faster it got. And the timing's almost halving after just about 5 to 6 trials of inserting, which just goes to show that practice does make perfect. When you're developing your own protocols, a simple way to start is actually getting used to establishing arterial access in the ED. That means inserting intra-arterial lines, which help with blood pressure monitoring in an ultrasound guided way, similar to putting your central lines, but just switching over to using an intra-arterial line. And that allows you access then to upsize that line into a sheath in the operating theatre, 5 French sheets for general diagnostics and angioembolization, upscale up to a 7 French sheet if you are applying Reboa. And what you do after that, once you have a sheath, and is really dependent on the patient now. Do you want to deploy Reboa intraoperatively? Do you want to just use it for diagnostics or angioembolization and other therapeutics as well? In terms of systems, in terms of building the system, it's important to centralize the training and the application of this initially, maybe restricted to a few people so that they can build up some expertise, get a lot of stakeholders who support you, emergency department, trauma, vascular, anesthesia, interventional radiology, hydrothoracic surgery if they are in your hospital, so that they all know that, that you are engaging in this level of complex polytrauma care. Go for the training courses. Be very clear about what patients you want to select for this in the initial stage so that you gain confidence in being able to deploy these methods. Have very strict audit and case reviews with your mentors and with your proctors so that you are able to audit and improve the system and keep feeding back in the system so the system gets better. All right. At the end of the day, anyone who understands line insertion, understands the anatomy, appreciates the physiology can do it. And I say this as a vascular surgeon. The American College of Surgeons and emergency physicians, they do suggest that trauma surgeons, acute care surgeons, ED physicians and IR learn the skill set so that it allows you to apply this in so many ways, both at the ED level, at the emergency room level, and the operating theatre. And certainly you have to make sure that you have vascular and interventional radiology teams who are available to deal with some of the complications and access point issues, such as the puncture sites in the event they have a problem. Right? So I think today we've just talked a little bit about endovascular access techniques and how it opens up a new front in our battle to achieve hemostasis in complex polytrauma patient and how that works together with damage control surgery. We talked a little bit about pre-hospital, emergency department, and OT applications of endovascular techniques. And again, and I thought as a practical tip for everyone about how to set up a system of having a hybrid approach to polytrauma and using these endovascular techniques to help with in complex polytrauma. Right, I think that's my last slide. Just leave you with a picture of one of my favorite places in Singapore. And once the pandemic is over, when everyone's visiting each other again, hope to see you guys in Singapore one day. Thank you.